Welcome back, everyone, to Andrew's podcast on YouTube, Food Skepticism. Today's episode is 6. It's January 26, 2020. We're going to cover non-celiac gluten sensitivity. All right, so a little introduction. Gluten represents actually several types of proteins in wheat, barley, and rye. It's not one thing. It's more like a group of proteins and that are similar. It can include ones like gliadin, for example. Sensitivity may affect up to close to 11% of the US population, but that number varies widely based on the studies, and part of that has to do with difficulty of diagnosis, which we'll talk about. It's classified by the Oslo Group, which is a medical group of consultants and experts who classify it as a gluten-related disorder, so it's a real thing. It used to be dismissed as placebo effect, in part because of the difficulty of diagnosis and because of a lot of issues with the studies that have been done on people and their responses to it. But it isn't now. We actually have some biomarkers, candidate biomarkers, that indicate that it's a real thing. It's a separate, distinct thing from celiacs. It also used to be considered the same as celiacs, but like I said, not now. And I just want you to imagine for a second what it would be like if you couldn't eat wheat, rye, or barley. Can you imagine all the foods that would rule out? All the pizzas, all the breads, all the pastas, all that stuff So that's why this is so important, is because when we need to cut out a whole group of foods, there's going to be consequences. And we need to think about that. A gluten-free diet is not considered a health diet unless you absolutely need it. Anyway, we're going to talk about that. So I want you to know another term here before we really get into it, and it's called FODMAPs. You're going to hear that a lot when amongst gastroenterologists or people who study like gut disorders and things like that. It stands for fermentable, and fermentable by what? Bacteria, stomach bacteria, intestinal bacteria. Fermentable di and monosaccharides. Di stands for 2 and mono stands for 1. So single or double unit sugars. And polyols, which are essentially like sugar alcohols. And sugar alcohols, it ends with all, therefore it's an alcohol. Now that's a real thing. Okay, so a little brief overview of what we're going to go over. First of all, we're going to cover the definition of non-celiac wheat sensitivity or gluten sensitivity. I prefer the term wheat sensitivity, and we're going to discuss why that is. We're going to talk about the signs and symptoms. How do medical doctors like gastroenterologists, specialists in the gut, how they diagnose it, some of the difficulties they face, and they are numerous, the causes or etiology as we know them, treatment, including nutrition therapy, some resources you can use or read up on if you want to check where I got my information, takeaways, things that you can walk away from this presentation with and you should stick in your mind really well. References, they're pretty much going to be all internal this time, so that page is blank. And as always, I'm going to ask you to like and subscribe this video if you like and subscribe it. Show your support, be notified when I post new videos, that sort of thing. And then we'll do a farewell question and comments slide. And as always, please leave your questions and comments in the comments section below. All right, definition. So again, its preferred name is non-celiac wheat sensitivity. And it is a sensitivity to gluten proteins in wheat, rye, or barley, as I mentioned. It may be present in as low as 0.6% of the population or as many as close to 11% of the population. We simply don't know because of the difficulty with diagnosis and studying it. It's classified as a non-immune and non-allergy related disorder, unlike, say, a wheat allergy, or unlike celiacs, which is immune. and its clinical presentation, that is how it shows up symptom-wise in the clinical office before you run a lot of extensive blood tests, is that it's nearly indistinguishable from Crohn's or celiac disease, which also plays a part in its difficulty of diagnosis. Okay, so some common signs and symptoms, they're very wide range, but they include some that are pretty common to the other ones, like irritable bowel syndrome and celiacs and such. And those symptoms are diarrhea, fatigue or tiredness, intestinal discomfort, and gastric pain or stomach pain, abdominal pain, bloating, changes to bowel movements, headaches or migraines, dermatitis, which is skin irritation or inflammation. Itis usually means inflammation or infection. Foggy mind, Borborygmus. Gosh, I don't know if I even said that right, but it's bubble guts. It's the scientific term for bubble guts. Flatulence or farting, muscle cramps, and leg numbness. So that just sounds terrible altogether. Okay, so diagnosis. Gastroenterologists often use the Salerno experts criteria for diagnosis. This is something that was developed, which is on the current evidence that's believed to offer definitive diagnosis. Patients must already be on a gluten-containing diet to start it, which is actually a big hindrance for many, because of course they don't want anything to do with gluten. Why would they do that to themselves? Anyway, but it begins by up to 6 weeks of a gluten-free diet, and it must show a 30 or greater % symptom reduction. Then that's followed by reintroducing gluten using a double blind. That means neither the doctor nor the patient is aware of which is which, the placebo or the real gluten. And that's a crossover design that lasts 6 weeks. And crossover means that they will be on gluten for part of that time, like say 3 weeks, and then part of that time, say the other 3 weeks, they'll be on non-gluten, and they'll make the switch kind of silently and randomly, so people don't know when it's been done. And that's to make sure that neither the physician who's administering the test gets biased and somehow telegraphs what the reality of the test or the results of the test. And it's also so the patient doesn't get biased as well and assume that, oh gosh, it's gluten in here, I'm going to feel terrible. So anyway, they reintroduce the gluten and they must show a 30% symptom return, 30% or greater. So as you can imagine, all this is a whirlwind of tests for people. And sometimes they even administer a self-administered survey called the Gastrointestinal Symptoms Rating Scale, or GSRS, which can kind of increase burden even greater. So, and there's no standard biomarkers, by the way, like no standard blood test that you can use that definitively diagnose this disease. So you can see that all this, and plus the additional ruling out of celiacs, irritable bowel syndrome, FODMAP sensitivity, Crohn's, etc., those are additional tests. So you see that this is very cumbersome, very arduous, and actually contributes to the fact that there's a higher attrition rate among people who do this. Now, here's some diagnosis difficulties, right? Some food for thought. A third fail to respond to gluten when they reintroduce it, which raises the question, what's really behind it then, if it's not the gluten? Half respond to gluten-free flour after the Salerno test. You would think that they wouldn't respond because it's gluten-free, right? So something weird going on there as well. There appears to be no significant difference in symptoms for followers of a low gluten or versus a gluten-free diet. And this is kind of perplexing. Because you would expect a dose-response relationship, right? You increase the dose of gluten and you get a greater negative response. Well, that isn't happening in many patients. Also, 20% of patients also meet the criteria for irritable bowel syndrome, IBS. So it's like, okay, well, what's going on there? Do those 20% of patients actually have IBS instead? Well, only science can tell. Other wheat components may also trigger inflammation or allergic reaction, not just gluten. So, for example, amylase trypsin inhibitors, ATIs, wheat germ agglutinins, and fructans, which is a type of FODMAP that's, well, it's found in fruits a lot, hence the name. So we got to ask the question, if you're a physician or patient, could it be a case of mistaken identity? And that's the purpose of the test, to figure out what's really going on so you don't cut out a whole category of food unnecessarily and you really get a diet plan that works for you. Anyway, the cause or etiology, it's simply unknown. It's idiopathic. But scientists have noted some relationships. For example, people with this disease tend to have slight increases in intraepithelial lymphocytes, which are like they're cells in the lymphatic system that they perform somewhat of an immune function. And antibodies to tissue transglutaminase, or TG. And so, glutaminase, that's an enzyme. It ends with ACE, and, it's related to glutaminase. But anyway, diagnosis difficulties. For one, the physician bias may actually hamper the diagnosis and treatments. A lot of physicians are rightly skeptical when a patient comes in and says that they are gluten intolerant. It's become something of a fad lately, and people swear they feel better on it. But scientists also are very much aware of the placebo effect and cases of mistaken identity. So that's why they have to do all these tests. So both of you are completely certain what's really going on. Averseness to following a gluten-free diet is common. I mean, we talked about this. If people think that a gluten-free diet is healthier than a regular diet, or if they themselves are firmly believing that they have a gluten intolerance, asking them to start with a gluten-containing diet before you run the test is they're gonna be averse to that. They're not gonna want to do that. Why would they do that to themselves? They're not gluttons for punishment. And so the Salerno criteria are also cumbersome. And like I said, there's a high attrition rate. A lot of people don't make it through all the tests. So they never get the definitive diagnosis that they actually need. And many will kind of go around and just kind of assume that they have gluten sensitivity. That's not the way to go if you want to be certain, but that's your choice. And it needs to be said that there are side effects to following a gluten-free diet itself. I mean, think about it. You're cutting out an entire nutritional food. And with that comes deficiency risks. It also lowers adherence, because think how much gluten is in a wide range of foods. And you got to cut all that out all of a sudden. Gosh, that's going to be tough to follow. But also, it's associated, cutting a gluten-free diet, with mental health problems, the onset of them, and increased mortality. So it is not a health diet. It's what you need to be healthy if you have a gluten sensitivity, and that's it. Okay, so treatment or nutrition therapy. Consider a gluten-free diet if there's the presence of anti-gliadin antibodies. So gliadin, remember, is a type of gluten. So if you have antibodies present to it, that's a pretty strong indicator that your body is having an immune response to it of some kind. And so it's just something to think about. If you're a physician or whatever and you want to run a test, there you go. The Salerno Experts Criteria tests, which involve elimination diet protocol. That elimination diet is like the removal of entire category and then the slow reintroduction of it to see what happens. Anyway, but that's what happens here according to Salerno's Experts Criteria test. Nutrition therapy is typically focused on counseling support, helping people stay adherent to the diet, as well as personalizing a diet plan for them. Treatment entails addressing and minimizing the side effects of gluten-free diets. This is important, physicians and patients. Like, you must insist that any treatment plan that your doctors come up with address the side effects of gluten-free diet. Otherwise, you put yourself at risk. And also, strangely enough, this is just like a little factoid, but many patients who switch to Senatori Capelli wheat variety instead of the typical American wheat variety actually end up with lower symptoms. So it's just kind of interesting. It might be something you seek out before you cut out gluten entirely. Maybe like a little simple test you can do yourself. But I highly recommend you see a doctor if you suspect you have gluten sensitivity. They can do the full range of tests that need to be done to be certain. Okay? And try testing a low FODMAP diet if the other tests are inconclusive, and if you're a physician. FODMAP diets have been notoriously successful, especially in a lot of Australian studies that have been conducted. It's been extremely successful in reducing a lot of the symptoms, and not just of gluten sensitivity, but also irritable bowel and the like. Here are some of my resources, and here's some takeaways for you. First of all, non-celiac's wheat sensitivity, and I prefer that term, wheat sensitivity, not gluten sensitivity, is real but often mistaken. But please adhere to tests because it's so difficult to diagnose. You should be doing your doctor and yourself a favor. And physicians should consider testing for anti-gliadin antibodies. They really should, because that's a pretty good indicator that they're on the right track. No internal or all internal references. If you liked and subscribed this, stands a reason you should like and subscribe my video, right? If you want more notifications about when I upload new stuff, if you just want to show and acknowledge the fact that you watched it and liked it, as opposed to disliking it. Actually, I'm kind of okay if you dislike it too. Just leave comments and questions so I know what's going on with that and I can fix stuff. But please like and subscribe. Any questions or comments, please enter in the comments section below.